This is Dr. Latasha McElwain with an overview of my GCU course, Case Management and Crisis Intervention Skills for Addiction and Substance Use. This is discussion topic for week 3. This is the GCU course, PCN 2550500. Again, that's PCN 2550500. So the first question here for this week's discussion, it starts with, what is the difference between screening, assessment, and treatment planning? Then the next question is, why is it important to conduct ongoing assessment when working with the client? And the third part of the question is, give examples of such scholarly sources to back up your definition. So I am going to talk through this based on personal experience and knowledge. So when you do answer this question, do want you to be able to go through your textbook and go through some other sources if possible to be able to back up the definitions that you are going to give regarding this topic. So what I will do is I will talk about screening, I will talk about assessments, and I will talk about planning. With talking about all three of these, I will also go into why it is important to always be assessing your clients as you're working with them throughout the duration of the time you're working with them. So the first one is screening. So screening usually is the time when we are trying to figure out like what's going on with a client, and rather than meet the criteria or for services that they're requesting. Lots of times what I tell people is when a person's coming in for services, we want to make sure that they are hitting the services that we are providing, and also that we are making sure that they are um, eligible for the service, meet the criteria for the service, can get the service, and kind of go from there. When we're talking about a screening when it comes to mental health and substance abuse, basically it's a standard set of questions that we typically ask people regarding their healthcare information, or basically a checkup that they're probably been sent to us for, or what the reason why they're coming to us, or if they have, signs of mental health or substance abuse disorders and concerns. So the questions help us as the provider be able to work with a person and figure out what is going on with that person's mood, that person's thinking, behavior, memory, lots of different things that we do catch up on when we're talking with the individual. When we're also doing substance abuse screening or substance use screening, we typically ask some of the same questions as well. And a lot of times in those questions, we are asking other things, like we are probably finding out what happened with the drug related risk incidents, what has happened if they've had some like DWIs, if they've had some criminal convictions dealing with drugs, possession of drugs, things like that. We're also asking them how much they use. We're asking them how often they use. We're asking them if they use in social settings, if they use every day. Some people get off from work and use every day. So we're asking them a lot of those questions. We may also have a urine test done. We might do a saliva test. We might do a blood test or something like that. That could be a part of the assessing screening process as well. But typically when we are screening an individual, we are really wanting to figure out what is the risk for the use of alcohol and drugs. And we also want to definitely work through and find out, kind of what's happening with that person, that not only are they here for a screening and for us to figure out, okay, what's going on, and figure out, where they kind of belong in services, because we do that also when we're looking at screening. We do try to figure out what part of our services they kind of belong in. I will say this: in North Carolina, we did I think it's the dimensions. I think I'm gonna try to Google it right quick, but I think we did the dimensions when we got our did our testing. Of course, I tested almost almost 20 years ago now. But I tested a long time ago, might be less than 20 years. I think I might have tested in 2008, 7 or 8. So a little bit less than 10 years. But we actually went through a complete list of dimensions and everything and all of the services that we provide, from screening to assessment to treatment planning to the services we provide and everything, in order to get our license. We have what they call an oral board. Um, and with that being said, we had to go through all of the different dimensions and all the different criterias and things of that nature in order to be able to pass this oral board to become a licensed professional. So just wanted to put that out there. The ASAM criteria also has dimensions as well that we had to be very familiar with also. So I always tell people, when it comes to substance use services, there are a lot of different components you definitely want to be aware of and you want to know about. In the screening part, also, we do try to get some information, some medical information, if we definitely want to make sure that we are doing a thorough screening on a person. But that's just to make sure that we are, covering all our grounds and getting all the information. As in, when we say medical, who's their provider, if they don't have a provider, where they've been getting care and things of that nature. So we definitely want to be under the same understanding of everything that we are going to typically provide for our clients. So when we start looking at the assessment, the assessment is normally, if you're a case manager and you're just doing the screening process, you're probably going to do almost like, and I always like to leave the screening process is almost like a needs assessment. And then the assessment piece goes into a actual clinical assessment, or it could be a little bit, where if you go into maybe a case manager that is probably not licensed versus a case manager that is fully licensed, then some of the things that I talked about in screening will be definitely in screening. And then that needs assessment may pop up under the assessment part, where you may have a social work or another licensed provider do what they call a full clinical assessment. So a lot of that to think about. We are still trying to figure out what's going on with the individual, how we can assist the individual, what we're going to be doing for the individual. In the assessment, we are going to be asking more questions. And when I mean more questions, we are going to be getting into the nitty gritty of some things. We are going to be going in depth. So we're not only asking you, who's your doctor, like medical stuff. We're not just asking you who's your doctor. We're asking you who's your doctor, where they located. We're asking you when the last time you went, when was the last time you were in the emergency room, what medications you're taking. Like we're gonna do a deep dive, even with your mental health. When was the last time you seen your therapist, and how long do you normally meet with your therapist? Do you meet with them on a weekly basis? Do you meet with them on a monthly basis? Do you meet with them on a because some people do it definitely on a maintenance basis. So if you're at that point, we're trying to figure out where you are pretty much in the game of getting your care. So we definitely want to know. Typically in this part, in our case management and counseling area, we are not doing psychiatric assessments. We are asking about medications. Yes, we're asking about, when they take medicine, how, and all medicine, not just your psychiatric medicines, but all your medications. But we are technically doing what they call a mental health or a substance abuse assessment, or even a needs assessment. We're not necessarily doing a psychiatric assessment because that's what a psychiatrist would do. We're not doing a psychological assessment because that's what a psychologist would do. But a lot of our information could be passed over so that it can help our psychologists on staff or our psychiatrists on staff get that information and use it more elaborately in their assessments, and they'll be able to add more to what's going on with that person. It adds more layers to what's happening with that person, and then it also puts them at a point where they can be more I guess on point, more deliberate, more intentional when they're making a diagnosis based on information that's been gathered from screening to assessment, to going into treatment and things of that nature. Normally, once we do an assessment and we gather all the information we need on the assessment, we usually do a biopsychosocial assessment. That's what we do as counselors, and maybe even case managers may have a piece of that they kind of work with or work within as well. And then at that point, we're trying to figure out, what else is going on, the mental health assessment and the substance abuse assessment. We are trying to figure out what else is going on that we are able to get the information we need in order to make a accurate diagnosis. So at that point, we're trying to ask a lot of different things. We're doing these assessments. We are getting identifying the family. We're identifying strengths that the person might have. We are identifying services they already have. Services, we're thinking about what services can be developed and they can work with. We're thinking about the monitoring process. Like I asked you, when you go, when last you went to the doctor, when last you went to the psychiatrist, things like that. We're asking about challenges. We're asking about things that services they're already connected with. We're asking about things that they're interested in going with. In the state of North Carolina, in our assessments, in the clinical assessments, we do a kind of some information that we ask, basically dealing with their crisis plan. So their crisis plan is usually attached to North Carolina's PCP, which is a part of their treatment plan, versus actually a part of the assessment. So we gather that information during the assessment, and then we work that information out to be a part of the assessment, as in what the crisis plan is, how that person get through crisis, what sends them in crisis, what'll trigger them, how do they cope normally, who can they call, and things of that nature. So we got a lot of good stuff happening when we're doing an assessment. And like I said, we're getting a lot of good information from people. Typically, during the assessment, we also examine related issues. We talk related issues, we talk about medical issues, behavior issues, social issues, financial issues. We are basically getting enough information to make sure that we can do, again, an accurate diagnosis of what's going on with that individual and come up with ideas and thoughts that will be helpful for them to work on through their treatment plan. And I say it that way because as we are working, we are also getting the information directly from the patient, client, consumer. They're putting their input in, because everything we do in North Carolina is person centered, and we try to make sure that we are working with the whole person. So if the person said I need housing, then we're going to have a housing goal. So that's kind of getting into treatment planning. We start talking about treatment planning. We are definitely in the midst of looking at what we're doing for this person. How is now providing services to this individual is going to be helpful in their overall ability to get services in place. So when we're talking about treatment planning, we are looking at all the things that we came together with from the assessment and from the screening, and we are putting things in place to try to make a plan outcome, a successful plan for individuals to be able to work and continue on. And this is basically the assessor, usually the therapist is the one who really creates this treatment plan, this PCP. They complete it, and basically they are making sure that, to their greatest extent possible, they're making sure that they are everything that they have, the information they have been given, they are able to make it applicable in the treatment plan to make sure that this individual's goals and needs can be met, that we have the resources, we have the services, we have we can put them in the appropriate level of care, whether it be inpatient, outpatient, group home, residential, or PRTF for children, which would be a lockdown facility, or in a residential substance abuse facility, or just intensive outpatient therapy, or intensive outpatient therapy, or I'm getting my words mixed up. If it's gonna intensive outpatient therapy or intensive outpatient substance abuse care, what is it? I forgot the other one. partial hospitalization, mental health, art, substance abuse, whatever the case may be. Different states have different services, but I'm just going through some of the services here in the state of North Carolina. But again, it does give you a multi-dimensional overview of all the parts to the assessment and the screening to create this treatment plan. And it's individualized. So the big things is individualized. And with it being individualized, that means that we're definitely making sure that we are addressing the problem. We got goals, we got objectives, we got interventions, we got things that we're going to do. And that's one of the biggest things that we have to make sure that we kind of put in place. We have goals that are reachable and obtainable for the clients, and the patients, that we can help them to deal with some of the things in their life, and those things that are beyond what we can do, then we can get them referred to services and resources that'll help them get to those places in life. So basically, we're looking at developing a treatment plan. We're looking at identifying problems. We're looking at setting goals and objectives. We're looking at the interventions that we're going to provide with this person, or we're going to be putting in place and trying to work through things. We're going to make sure that we try to develop a strong treatment plan to make sure that we can get this person from point A to point B to point C. Wherever they're wanting to go, that's our goal, is to try to get them there. So those are some of the things that we talk about when we're considering the difference between a screening and then coming in for the assessment and then doing a treatment plan. I remember when I did do my substance abuse license in North Carolina, I remember that when we did the screening part was really not as in-depth as I'm saying it is now. That's when I first got in the field and I knew, but I didn't know, but I was doing more book knowledge. But as the book knowledge that I can recall when I did my oral boards, when we did screenings was really just more of getting the person's demographics, finding out where they're from, what service they're trying to get, and things like that. And then, trying to, kind of put them through a process where I got enough information to pass them on for the assessment to be able to begin, for, me to go ahead and schedule the next appointment, which would be the assessment appointment with the therapist. So that's kind of how I learned about screening, assessments, and treatment planning. But over the years, like everything that I just mentioned is what has developed out of my experience of screening, assessment, and treatment planning. So those are some good tips, I think, and some good ways to think about it. One of the things I'm going to say, why it's important to conduct ongoing assessments with your clients, your patients, your consumers, is because things change. So I always tell folks that, well, in the state of North Carolina, we have this thing called the addendum. So we can do an addendum to an assessment if something has happened or something has been triggered in someone's life. So say I'm working with Patty, and Patty, lives a different lifestyle, and she's kind of out in the streets and doing different things of that nature. Sometimes she'll go lay up at mom's, and maybe go hang out with dad or whatever, or sometimes she'll go to this boyfriend's house or whomever, and this little friend's house and stuff. But as Patty is out there in the street, Patty's dealing with a lot, and Patty came in and say she has been traumatized. She was, taken against her will and kind of maybe human trafficked for a little bit, and some things happened in that time period. Well, yes, at that point, I would be working with Patty to go ahead and do more assessing, do an addendum. If she's been gone long enough, we would do a reassessment, period. But if, Patty's been gone for a week or two, and then something comes, then she pops up and then something has gone on, then we're going to respect that and honor that, of course. And we're going to do an addendum to the assessment to add some of this trauma in, so that we can get some trauma focused and more trauma-based stuff happening for her. So that's one of the reasons why, or even let's just say, Kathy went out, and Kathy ended up being in a real terrible car accident, and we were still seeing her, but then we started realizing, a few months down the line, that she might be suffering from post-traumatic stress disorder, because things are getting a little bit more intense for her. So with that, we're going to work with Kathy and see what's really happening, do a reassess, and we're going to listen to Kathy the whole time. A lot of times I like to listen to my patients, and if they tell me something is wrong or something is different, then I like to try to jump in and reassess and do addendums if I need to, and update those treatment plans so that we can be focusing on those things or getting those things addressed, because I don't want anyone to be sitting in services and not having the reason they're there being addressed, and then something else happens, or the reason why they're there is being addressed, but something else happens and we have no idea what it is. And then it's almost like, when were you going to address that? Well, they mentioned it, but no, you have to be the clinical person that really kind of look at stuff and kind of go more into detail, ask more questions, and do all of those fun stuff that's going to make sure that you are able to adequately service this individual and give them what they need. That's what we're here for. So a lot of times I tell people, even though, I've been in places where I've seen people do the bare minimum, but then I've also been in places where I've seen people be very thorough. So in my private practice, we're pretty thorough. We go through stuff and we make sure, is it bothering you in that way? Do you think we need to address it now? I mean, we ask those questions, and we also make a clinical judgment. Well, I know you said you didn't think so, but you brought it up 5 times in this therapy session, 5 times in this conversation we just had. So I think there might be some, unresolved feelings there. Is that something we can look at? So, I'll interject. And even if they say no, guess what? I'm going to make a note, because I'm going to hit it up again next time when they come back, especially if they bring it up 5 more times in the next sessions. So I'm saying that to make sure that people understand that, continuing and ongoing assessments. Oh, another one that comes up too is sometimes everything's nice and stable and things are kind of rocky, but rolling, rocky but rolling, and things are nice and as stable as they can be. They're stable enough, and if it's stable like that for the last few years or whatever, you've been working with a person for the last few years, and then all of a sudden the rubber hits the road and that person is homeless. Oh my goodness. Well, guess what? We have to do an addendum to that assessment, or a brand new assessment. If it's not through because an assessment is usually good for 1 year. If that assessment, the rubber hits the road, and we're 3 months into this new assessment, this new treatment plan, then we're going to reassess, and we're going to not we're going to reassess, we're going to do an addendum, and we're going to keep moving so that we can add the housing goal in for that person. Okay. And that makes sense because something has changed in their life. Something as drastic as housing. Yeah, something has changed in their life. Not that they're going to live with boyfriend, they're going to live with, a friend that they're planning for or something. They just got kicked out of the house. Mom and dad said, we're done, or whatever the case may be. Boyfriend said, it's over. A husband says, you got to go. Wife says, you got to go. So when these things happen, we jump in and we try to figure out, okay, what's the next step and what can we do? So now we have a housing goal. And the whole time, all we've been working with this person was mental health, substance abuse, or we've been working with them just strictly substance abuse, and now they're homeless. So what are we going to do? We're going to try to kick in and try to figure out what we can do to help and come up with some plans, even if we're to the point where, okay, let's say if mom, dad put them out. Mom, dad, can you pay for a hotel for a few days so we can kind of restructure, regenerate, try to restructure and get some things situated. Or, we can figure out what's going on at the shelter. But, what if something's going on, and especially if sometimes people go to the shelter, they get kicked out. I mean, just a lot of dynamics and a lot of stuff happening. So with all those parts moving, we try to make sure people are understanding of, okay, what is as case managers, what is to come or what could come. And believe me, there's never a easy day, but there's never a dull moment, put it like that. Not an easy day, but a dull moment. And everything could be a little challenging, but once you've been doing it for quite some time, it becomes pretty much second nature, and it's not that challenging to you. It's just, part of what you do, and you move on. You try to make sure that everyone has what they need so everyone can move forward and, get along with life, or figure out what the new, I like to say that word, the new routine, or creating that new piece of life now that exists because something has changed. So a lot of times that's the big part of treatment planning, and making sure that you're assessing and reassessing or doing an addendum to an assessment or anything like that, just to make sure that you're getting something nice and fresh on that person. And when things change in their life, that you are on top of it as well and willing to assist them with those changes and move forward with that. So with that being said, that is the discussion question for week 3, and our case management and crisis intervention skills for addiction and substance use. Again, this is my course with Grand Canyon University, and this course number is PCN 255-0500, and that course is typically taught most semesters that I am teaching. So this is just a little heads up for you. Again, this assignment is this discussion is asking that you have some scholarly sources to back up your definition. So again, I am giving you information based on experience, personal experience, professional experience, working in the field. And then I'm also wanting to make sure that everyone is aware that they do have to have some scholarly sources to back up their information. Okay. So with that being said, I'm going to move on to our next video. And I hope this has been helpful for everyone, and this is something that will push you forward and make sure that you have a good answers to add to our discussion, as well as to get some good feedback. Thanks so much, and I hope you have a great day.